Thank you for joining the third Congress. I'm going to introduce our moderator, Mr. Riyad Elbard. He's president of the Thalassemia Foundation of Canada, has been a leading member of the Thalassemia Foundation of Canada for over 25 years. He's dedicated to advocating for optimal care of all thalassemia and hemoglobinuria patients. He represents the foundation on various committees and has been instrumental in building and maintaining strong collaborative networks with partners and stakeholders. Riyad, with a special interest and expertise in blood safety, represents the Thalassemia Foundation of Canada on the board of directors of Thalassemia International Federation, where he's been serving in that position of the treasurer since 1998. So without further ado, I will hand this over to Mr. Riyad Elbard. Thank you so much.
Thank you, Samuel. Hello, everyone, and welcome to all of you joining us from across the globe. It's a delight to have you with us. We have an interesting session today, this morning here in Canada's time, and it's on the comprehensive care and management of thalassemia. We have two distinguished speakers that I will introduce shortly. First, we will be discussing identification of and genetic counseling in thalassemia. And second, we will discuss iron chelating agents and recent therapies in the management of thalassemia. Our first speaker is Dr. Yi Yap. Dr. Yi is a clinical hematologist working at Ampang Hospital, Ministry of Health in Malaysia. She underwent an internship at Kuala Lumpur Hospital and a residency at the Duchess of Kent Hospital. She subsequently obtained her MRCP from Glasgow, Scotland. She is specialized in clinical hematology and did her fellowship in hemostasis and thrombosis at the Perth Blood Institute in Australia. She also has acquired her FRC path in the UK and London in 2022. She is also the president of the Malaysian Society of Patient Blood Management, and she has been practicing patient blood management for many years and has vast experience in treating thalassemia and bleeding disorder patients. Please welcome Dr. Yi. You can start your presentation anytime you're ready.
Thank you, Mr. Riyad Elbard, for the kind introductions. Can you all hear me?
Yes.
Yeah?
Yes.
We can hear
Okay.
you.
I just wonder how to make my screen smaller. Out there. All right. Okay. So I'll be bringing you through. By the way, I'm Dr. Yap. Yi Yap. Yap is my surname. Yeah. So the outline, I'll be speaking to you with regards to the morphology of thalassemia, and I'll bring you through what are the advantages and disadvantages of the methods for thalassemia testing, and followed by the genetic counseling, what is the importance of it, and last but not the least will be case studies. Yeah. Right. So this is the algorithm or the flow chart that we used to work on if we receive a full blood count. So we usually look through not only from the hemoglobin, we also pay attention to the MCV, MCH. When it's less than like 76 or less than 27, that will actually assess it whether it's due to iron deficiency or whether it's actually thalassemia trait. And when it is low, we also go through those with strong family history of thalassemia, as well as when we look into other indices, like, for example, the red blood cell is high or the red cell distribution width is actually normal, because in iron deficiency anemia normally is increased. So for this sort of category, we'll go through what we call a HB analysis. As you can see, with the HbA2, which is your alpha-2, gamma-2, that less than 3.5%, normally we suspect either due to alpha thalassemia or due to iron deficiency. If you look through this 3.8 to 7%, this is where we suspect the patient has beta thalassemia trait. And more than 8%, we have to exclude those like structural variants. And for those like above 76 and 27 picogram for the MCH, probably is most of the time is normal. Of course, there are some beta thalassemia trait may have this normal indices as well. Yeah. So these are the full blood picture or peripheral blood film of a thalassemia major. As you can see with the red cell changes is very marked with the different shapes and sizes and isopoikilocytosis. And you can see this particular patient, you can very easily pick up they have hollow jolly bodies in the red cells, where signify this patient is actually post-lymphadenectomy. And it has a lot of nucleated red as well. If you look at the red cell, the most of them is like hypochromic, microcytic as well. You see, pretty small. And there's also a lot of shapes like teardrop changes. And you can see the red cell, the changes, not only target cells like this, they also have like alpha inclusions, whereby they have excess of the globin chains due to that. And you can see like abnormal distribution of the hemoglobin as well. So it's really, really bizarre looking at the red cell for major. Now, this is the blood film for the intermediate one. You can see the changes is less marked compared to the previous one. And this patient, I'm sure the spleen is not removed. And he has target here. And I can see from the blood film looks likely it has a E beta in a sense for the thalassemia intermediate, which is quite prevalent in Malaysia. And this particular one, unfortunately, the picture is not so clear. It's actually a basophilic stippling. Now, this is a trait. This you can clearly see this particular blood film. It has, okay, this patient I put up because it has like a dimorphic picture. The reason being because there's normal red cells and also hypochromic microcytic in the background. This particular patient is actually one of my ladies with thalassemia trait, at the same time has iron deficiency anemia. So what I'm trying to say is thalassemia trait, they also can have concurrent iron deficiency anemia at the same time. As you can see, because she has iron deficiency anemia, as a trait, she has nucleated red due to stress marrow. Now, this is another spectrum of the disease. Just now I show you all beta thalassemia spectrum. Now this one is alpha, which 3 gene deletions. You can see this is the HPH disease, where this is also very marked changes. You can see a lot of polychromasia, the purplish color, reticulocytes, which is increased. And this is actually basophilic stippling. I was showing you this is a better picture. And there's a lot of teardrops. And also in this particular patient, it has a bit of acanthocytes. You can tell this is actually echinocytes. If I'm not mistaken, he has a bit of renal impairment. And now this is from the low power on the peripheral blood film. And this is what we did with the supravital stain, the brilliant crystal blue, where it will actually stain the red cell become golf ball due to the remnants of the RNA excess that is staining it to become like this. Normal full blood picture, you won't be able to see it. Okay, this is another one which I want to show you. Now, this is a very interesting case because this particular case, although it's like 3 gene deletion, HPH, with the Q thailand, which normally one of the alpha mutations that happen. So it happens with the alpha plus, 4.2 normally. And then they usually inherited, in this particular patient, inherited with the Southeast Asia 2 gene deletion alpha 0. You can see the changes of the full blood picture is slightly different from the previous one with the 3 gene deletion. It's one of the call it what, deletional HPH, which they also have a bit of intermediate clinical phenotype as like the previous one. Now, this is a sickle cell disease. Just to let you illustrate to you, you can see the sickle red cells here with lots of boat shape as well and target red cells. And you can actually pay attention to the red cell in comparison to thalassemia. They normally has very normal MCV and MCH, yeah? Because the red cell usually is quite normal size and shapes if you compare. Now, this is another one which have some crystal in between, which is a HBC. And you can see, which is quite common in West Africa. There's a nucleated red. If you pay attention, you need to look for in this particular sickle cell disease, and they have a lot of target as well, which may signify underlying beta. This one actually, I think, you have to look for hyposplenism, which is not present here due to which is in presence of hollow jolly bodies. Now, this is the developmental hemoglobin that we talked about. What's the reason when the patient is born, for example, like a newborn? If you can pay attention, when we were in utero, right? We have all this embryonic hemoglobin due to your Portland as well as your Gower. But to a certain extent, when it reaches like 6 months, it will convert into your fetal hemoglobin, yeah, which is this, and that's where it forms. And if you pay attention to it, what's the reason, the advice not to do HB analysis at birth? The major reason is because of this, the beta globin chain. If you look at it, it only start to rise after 6 months after birth. That's why a lot of patients, when they are just born, unless we are very sure it's a beta tau major, where you can see very high fetal hemoglobin with the absence of adult hemoglobin. Because adult hemoglobin is usually alpha 2, beta 2, which you can have it present about 20% to 30%. If it's completely absent, then you can detect them. But if you are talking about beta thalassemia intermediate trait, it's very difficult. Whereas for alpha, on the other hand, you can actually do molecular diagnosis from the beginning at birth. Now, this is all the normal levels in adults. Adult level 96 to 98%, fetal hemoglobin less than 1%, and HbA2 usually should be 2 to 3.5%. Now, this is the differences between the thalassemia and IDA. I think I don't need to go through so much, but just to highlight to you, the red blood cell is the most important. Normally, what happens is for our hemoglobin, right, you should be able to get the ratio divided by 3. For example, your patient is like HB of 15. Then you divide by 3, you should expect about 5, correct? But if let's say you have a 6 or 6.5 or even like above, you should suspect is due to thalassemia. Yeah. And the rest is pretty similar with IDA. Another one is the red cell distribution width, whereby in thalassemia is always normal. Another one is MCHC, yeah, is your clue. Now for theta thalassemia, to me, trait normally you have to be careful because the HB may be normal. You're talking about like carrier. But when the MCV, MCH is low, you should raise a suspicion. For homozygous beta thalassemia, they will have no, for example, like the one I was talking about, the thalassemia major, there would be no adult hemoglobin, very easy to tell. The compound heterozygous will be difficult. That's what I was talking about at birth if you want to detect. And for alpha thalassemia, the one I was talking to you, the one gene like alpha plus is present in Indian, African, Mediterranean, and MCH more than 25. And this alpha 0 is the one Southeast Asia I was talking about. The MCH normally is less than 25 picogram. And for this alpha plus again, but it actually has 2 gene deletion if you look at it carefully. Yeah? It has a very marked reduced MCH and mean cell hemoglobin. And this 3 gene deletion, the HBH, beta 4 disease, usually HB is like a beta, like a thalassemia intermediate, where you have splenomegaly as well as HB 8 to 9. And this, the rest, which you have non-deletional, usually you have HBH disease in combination with constant spring, which is about 32 amino acids added to it, where they have marked splenomegaly as well as lower hemoglobin. And of course, for this with 4 gene deletions, which is the gamma 4, they will have even hydrops fetalis due to HB bars. Now, these are changes in HbA2 in some of the conditions I would like to let you know. Apart from beta thalassemia, it can be present in HIV, antiretroviral drugs, B12 or folate deficiency, hypothyroidism, and also when it's normal, it can also be detected in alpha thalassemia. And for reduced HbA2, not only in alpha thalassemia, it can be seen in delta thalassemia, as well as the iron deficiency, lead poisoning, hypothyroidism, and also JCMMOL. Now, this is where the chromosome reside for your alpha globin chain is at the chromosome 16, and beta globin chain is at the chromosome 11. Now, this is another method. Just now I was talking HB analysis, right? This is actually a gel electrophoresis. So what happened in HB analysis is actually going through a capillary. Yeah? For the gel electrophoresis, it's actually going through an agarose gel. It also have the same principle from cathode to the anode. As you can see how the hemoglobin is migrating. So they will separate to the distinct band according to their weight. You can see this one, it migrates through, right? You can see this is adult hemoglobin and followed by fetal. And then you can see some of them actually co-elute, like your sickle, your D. bunjab, your G. Philadelphia, your lepro. And this is actually another band which is showing you co-eluting with your C. HBC, E, which is prevalent in Malaysia, O, Arab, and also the HbA2. Whereas for acid, on the other hand, which is running at about 6.4 pH, the other one is running about 7.4 like that to 8. So this is where it will elute. You also from cathode to anode again. You can see the fetus band is here. The adult hemoglobin correlate with E, and the dibunjang and lepro again. And this is for sickle with O, Arab. And for C is distinct. So what is the good thing about the acid? It's usually very helpful in identifying fetal as well as sickle. It's very easy to, not to say easy, it's very cheap to perform this test in comparison to other tests. So this is the capillary electrophoresis, the machine called Serbia. This is the old one that I have. And this is another one that I was doing for the gel electrophoresis I was just describing to you. That's how it looks like. Pretty small, easy to actually carry around. Now, this is the Serbia I was talking about, where you have a thermic bridge temperature, hemolysis, dilution. It used to be, but nowadays you can actually run on the whole blood. And the capillary in the silicate conductive raceme, whereby you can see the cathode to anode, and there will be a detector with a direct quantification at about 415 nanometers. Now, this is the methods to compare, where I classify them. One is protein-based, the other one is more DNA-based. So what is the good thing about capillary electrophoresis, for example, the one I went through? It is fully automated, high throughput. It can separate the HbA2 from HbE, which is very common in our this part of the world. And of course, in comparison to the other methods, it runs with the equipment and reagents, and it requires technical skills, and it has a post separation of HbS from DIDO. And usually you need about 1 ml of the sample. Whereas in comparison to the other methods, which is also commonly used, is a high performance liquid chromatography. Yeah, it has high precision as well. The good thing compared to CE, it has like a very small sample it can actually run, like a fraction of a blood spot. So it's very popular to be used for newborn screening. You can see 1 ml is actually a lot of blood, from a newborn. So this is standing an advantage in comparison to CE. And the only disadvantage of this particular method is it cannot distinguish the E from like A2. It elute together. The retention time will be similar. That's the problem. So, however, the principle of the method is slightly different because it runs on different medium and it runs on due to pH changes. So in a sense, if your lab has these two methods to compare, would be better. And this is electrophoresis, as I explained. And this usually not many people is using it, isoelectric focusing, which I'm not going to mention. Now, this is a DNA-based methods that nowadays a lot of people using it for GAP PCR, which can identify a lot of common alpha thalassemia deletions, as well as beta thalassemia, and also hereditary persistent fetal hemoglobin. And you can see the problem with PCR, all this molecular testing, is always very limited to selected places. And of course, the cost will be much more compared to protein-based. Another one would be traditional DNA sequencing like your Sanger, whereby you can identify insertion, deletion, the indels, which is quite commonly. But however, if you do it, the problem with this Sanger, it only can run one sample at one time. And it cannot identify large deletions or duplications. Another one which is commonly done is multiplex ligation dependent probe amplification, MLPA. Again, it can detect large deletions and also duplication, which is very popular for alpha and beta genes. And the rest will be like NGS, of course, nowadays, which is the most sexy test in the molecular world. However, it comes with the reagents and also capital cost. But of course, it's still less than Sanger sequencing alone. The other than that is allele-specific oligonucleotide testing and also restriction fragment length polymorphism testing. Now, what is the importance of having genetic counseling? So before that, we were just looking at blood film. As you can see, right, the morphology of all the red cells, unless you have vast experience in looking through this sort of blood films, otherwise, based on morphology alone, to classify them is very difficult. And there comes the protein-based methods, whereby your HB analysis. However, you can see the limitation of your capillary electrophoresis, your HPLC, as well as the gel, is still very much limited. How to identify the gene mutations? But when it comes to molecular, it has brought the thalassemia diagnosis into a different spectrum, whereby we can actually identify specifically, for example, like hemoglobin S, C, D puncak accurately, at which point or break point, as well as O Arab and E, for example, and also Lepore as well, which you can firmly tell the patients about the future risk of having an affected child or not. And secondly, of course, detection of carrier. All of us know this thalassemia is actually an autosomal recessive disease. It can be actually inherited. And that's where, like in Malaysia, we have about 10,000 patients with thalassemia, of alpha 0 especially. Later, I'll show you a case. Why is it important to identify them? And a beta thalassemia. Because as all of us know, having a beta thalassemia major, or as well as the alpha thalassemia major, it can be a huge healthcare burden. And it's recommended that subjects of all ethnic groups to be screened for beta thal trait, except Northern European Caucasian only, because they only have variant hemoglobins. So it's not really essential. Now, this is how we look at it. This is just a simplified diagram. When you have both parents have thalassemia, for example, affected man and affected woman, both have thalassemia, your affected child will be up to 100%. Full stop. Yeah. When both parents are thalassemia carriers, for example, like a trait, you have unaffected child about 25%, 1 in 4, and carrier child is 1 in 2, like a 50%, and affected child is 1 in 4 again, 25%. So when a parent is thalassemia carrier, one parent married to a normal one, for example, chances is 50% you get normal, only 50% get a carrier. So this combination is much better. Whereas one parent affected by thalassemia, for example, with a normal person, it will be 100% carrier. When a one parent is a carrier and one parent is affected by the thalassemia, for example, these combinations, 50% is a carrier, 50% is affected child. Simple, yeah? Now this is case 1. I have a 19-year-old Chinese lady presented with first pregnancy, teenage, unbooked, antenatally poor follow-up, and at 37 weeks with a fetus showing cardiomegaly. The partner is also a teenager, 18 years old, Chinese gentleman who was well, Chinese boy, I'll call it. Detailed scan noted fetus has pericardial effusion and ascites with a hepatomegaly. Now, these are indices of the couple. The HB was 14, MCV was 80.3, MCH 20.8 picogram. White cell is pretty normal. Platelet is 243. If you pay attention to the red blood cells, again, I was telling you, right? HB 14 divided by 3. It should be 4 point something, right? Correct? It would be just 4.5. But this markedly raised. Again, and the MCH is also very low. Unfortunately, I don't know whether they have been screened at all. I suspect they were not being screened. And this particular lady, which is carrying the fetus, HB is 12.8, MCV is 70.0, MCH is 21.9, is markedly low, less than 27 picogram. White cell is 8. Platelet is normal again. If you look at the HB divided by 3, which is 4, right? This red blood cell is also very high. So unfortunately, the lady came into labor. So what I can do, I can run the urgent HB analysis. I don't get to do any molecular testing at all. As you can see, HB analysis is not very informative. Adult hemoglobin, 97.6, normal. A2, 2.4, which is within the range. And again, this actually on your left is the male one. On your right is actually a female one. You can see adult hemoglobin is present again, 97.9. But if you pay attention to the HbA2, this lady is very low. I strongly suspect she is having iron deficiency anemia at the same time. So this is the full blood count of the baby. It was born. The HB is 9.7. MCV is 91.2. Newborn with the HB 9.7 is usually very low because they should be a bit highish. They towards like very polycythemic range at the adult. MCH is 23.1 picogram again. Okay, platelet is 118. white cell is 49.9. So this white cell is very erroneous. So if you run on a full blood count counter with the impedance, normally they'll pick up the nucleated red blood cells as your white blood cells. You can see 137 in this particular newborn. So you have to be careful whereby you have to correct it according to the nucleated rate. And you can see the red blood cell is 4.2 divided by 3, it should be 3, right? It's a 4.2, it's raised again. Now, this is the appearance of the baby. Unfortunately, this baby, few hours later, he died. So you can see the whole body is swollen, and this is cyanose. And there's a very marked ascites. You can see it's a very obvious hydrops fetalis. And when I managed to get the umbilical cord blood and ran it on my HB analysis, you can see the one disadvantage of this capillary electrophoresis again, without the adult hemoglobin, it will lose, the zonation of all this peak. They won't be able to label for you. You can see. So what is so obvious here? This is obviously the BARTS, 85.4%. And the rest you can see, which is present, we are suspecting, is the embryonic one that's still there. Galba, Portland, Epsilon, and seriously, and when I try to mix it with my donor bloods and try to make the zonation there by the CE, you can see finally it comes about 4.4, 44.2 due to the dilutions. And finally, you can see this is ignored, this is due to the donor. So what we can conclude, the baby is actually 4 gene deletions, HB BARTS hydrops fetalis. So, and this is a gel electrophoresis. I managed to run it of the baby. You can
I
see.
regret to interrupt, Dr. Yap, but you be
Oh,
mindful
it's a
of the
time number, is it?
Well, you have a couple more minutes, so.
Okay, thanks. So this is I want to be quick. Okay, this is a fast band of the baby, just to illustrate to you the AFSC is ahead of the adult hemoglobin. Sorry, I'm going to be quick. Now, this is a case too. 33-year-old Chinese lady with HPH disease. She just got married. The husband did a HB analysis back in 2023. It has normal adult hemoglobin 93.1, HbA2 6.5, fetal hemoglobin is normal, which is a beta tau trait. So the lady is going to ask you, what is the chances for her to have an affected child? How will you counsel her? Now, so, okay, I'm going to be quick. This is my last slide, I think. So the court there is saying a lot of people mistaken, thinking beta thalassemia combined with the alpha will be a problems. The good news for this lady, actually, co-inheritance of both alpha and beta thalassemia in this situation will actually lead to correction of the globin chain imbalance in a beta thalassemic. Therefore, the child that she was going to have would have an improved phenotype, despite she will have 50%, even though affected child down here, you can see, it would have a better chance in terms of the hemoglobin compared to her. Where the other 50% would be carrier, as if you remember the diagram I showed you beforehand. So this is my last slide. My take-home message is, it's very important. I want to highlight here is the importance of identification of a thalassemia, as well as correlation of genotype and phenotype. And last but not the least, prevention is better than cure. Why is this genetic counseling is important? I want to highlight. If you identify a significant risk of going to have an affected child, for example, up to 50%, you should counsel the couple for pre-implantation genetic diagnosis, as well as prenatal diagnosis. Thank you very much. That's all.
Thank you. Awesome presentation. We will go next to our next presenter. We have Dr. Suman Jain, and she will be presenting on iron chelating agents and recent therapies in the management of thalassemia. You can write your questions in the Q&A, and we will take them at the end. Hopefully, we will have enough time. Also, you could always email Gansett to if you have any questions that we couldn't answer today. Let me just introduce Dr. Jain. Dr. Suman Jain is the Chief Medical Research Officer and Secretary at the Thalassemia Sickle Cell Society in Hyderabad, India. She holds an MBBS degree from Calcutta University and a diploma in child health from Mumbai, specializing in the management of thalassemia and sickle cell disease. At Thalassemia and Sickle Cell Society, Dr. Jain leads a multidisciplinary team providing free consultations, transfusions, counseling, diagnostics, and comprehensive patient support programs. In addition, she serves as a senior research officer at NIRI Kshana. So please welcome Dr. Jain. And Dr. Jain, we welcome you to start your presentation once you're ready.
Dr. Jain, you're muted and I have your screen shared. I can advance your slides for you.
You are sharing?
Yeah, so if you want to unshare your screen.
Yeah, please.
Perfect. Okay, just let me know when you want your slides advanced.
I can advance.
I'll be doing it for you, so just give me a prompt. Just let me know when you want the next slide.
Yeah, next slide, please. So today my topic is iron chelating agents and recent therapies in the management of thalassemia. And I have been introduced by Riyad. So I don't want to say any other thing. Next slide. So already Dr. Yap has already talked about thalassemia is an inherited blood disorder requiring lifelong regular blood transfusion and medications to remove iron from the body. It leads to various complications including iron overload, which is referred to as second disease in the treatment of first, because we are giving blood transfusion and with that the iron is also coming with in the body, and which is causing second disease if you don't chelate properly. And iron overload leads to serious clinical complications like heart disease, cardiomyopathy, arrhythmias, liver cirrhosis, and a lot of endocrine disorders if not treated at the right time. Even non-transfused patients develop iron overload secondary to increased intestinal dietary iron absorption. The human body has a mechanism for iron absorption but lacks an active pathway for iron excretion, a critical concern in the thalassemia, which leads to the risk of iron overload. Next slide. So the treatment of iron overload is only one option to remove excess iron from the body is phlebotomy and chelation. Phlebotomy is an effective way for removing excess iron in conditions like hereditary hemochromatosis where patients have normal or high hemoglobin levels. But in thalassemia patients, it is not possible because they are transfusion dependent. So there we have to go for iron chelation. And instead, iron chelation therapy is the standard treatment for managing iron overload in thalassemia. Next slide. So we have iron chelation. When we do iron chelation is recommended in patients when serum ferritin is more than 1000 nanogram per ml, or they have received more than 10 to 15 transfusions, or who have got a liver iron concentration. So compliance with chelation therapy and adequate dose are crucial factors in achieving prolonged patient survival. So patients who are having a good iron chelation, they are leading a life up to 50 years, 60 years, even 70 years also. But with poor chelation, the lifespan is only 10 to 15 years. Next slide. So we have got two types of iron chelator drugs, two oral drugs and one parenteral drug, which is desferoxamine, which is a hexadenate chelator, and defriprone is bidentate chelator, and deferricirox is a tridentate chelator. And route of administration for desferoxamine is subcutaneous or IV, And defriprone is a short half-life, so it has to be given orally 3 times a day. Deferisox has got a long half-life and it can be given once in a day. And dose range accordingly, like desferoxamine is 30 to 60 milligram per kg per day, and defriprone is 75 to 100 milligram per kg per day, and deferisirox is 20 to 40 milligram per kg per day. As I've already talked, half-life is very less for desferoxamine, so it has to be taken 8 to 10 hours in a day subcutaneously through an infusion pump. And defriprone 2 to 3 hours, so 3 times a day. And 8 to 16 hours, so once in a day. So where is the main site of action? It is basically desferoxamine remove iron from the plasma, not from the organ. So extracellular plasma iron has been removed from desferoxamine. And defriprone is intracellular, like cardiac iron, it removes mainly, and deferisirox is plasma and hepatic iron. And efficacy is excellent for desferoxamine, and defriprone is moderate, and deferisirox is again the excellent. And cardiac iron removal is the basically defriprone is basically cardiac iron removal, and mode of iron excretion is through urine and bile in desferoxamine, and from urine is defriprone, and deferisirox is from stool. And major adverse effect is for desferoxamine is ototoxicity, visual changes, growth retardation, and local pain. And defriprone basically agranulocytosis and arthralgia, GI upset, and deferisirox renal dysfunction and hepatic enzymes elevation. And monitoring is required when we are giving these drugs. Audiometry in case of desferoxamine, and weekly or bi-monthly is complete blood picture for defriprone, and serum creatinine and urine protein and LFTs for deferisirox. Adherence is very, very important. For iron chelation, desferoxamine is very, very low because it has to be taken subcutaneously, and moderate for defriprone, and very high for deferisirox. And use in pediatrics is commonly historical. It is from very long time this desferoxamine is there, and this deferisirox is very recent drug. It has come in 2006, and cost and availability is very expensive desferoxamine, and moderate expensive is defriprone, and again expensive is deferisirox. And preferred situation is high hepatic iron and young children, we prefer to give desferoxamine, and cardiac iron overload we give defriprone, and chronic hepatic overload and convenience is for the deferisirox. So contraindication for these drugs are severe renal disease, history of granulocytosis, and severe renal and hepatic impairment. Next slide. So what happening, we are getting lot of patients, what we are finding here, when they cross adolescence period, they are not taking medicines, so iron overload is very, very high. So there we have to give combination therapy. Best combination therapy is deferisirox and defriprone, and followed by defriprone and deferisirox, and defriprone and deferisirox. And triple therapy has been used, which is investigational, and small scale studies have shown rapid ferritin improvement and LIC reduction. And takeaway message is defriprone and deferisirox for cardiac siderosis, and deferisirox for hepatic overload. And adherence to the treatment is very, very important. Counseling is very important. They have to accept the disorder and take the treatment. Next slide. So what we were talking about, the newer therapies have come into the market. One is the pharmacological interventions like luspatercept, which is working very well. It is delaying the transfusions, and so that the iron overload will be less. Recombinant fusion protein it is, and it approved by the FDA in 2019 and an EMA by 2020. Mechanism, it blocks TGF beta signals that stop red cell maturation and effect enhances RBC formation and reduces transfusion needs. And another drug simultaneously, sotatercept, is a ACE011. Again, it is a fusion protein derived from ACT-R2A receptor. Okay. Another drug is mitapivat. It is it, back. So another drug which is experimental is mitapivat, AG348. The mechanism is boost ATP energy, is protease kinase receptor activator, and it lowers 2,3-diphosphoglycerate in RBC and improves RBC lifespan and oxygen carrying capacity. It approved by PK deficiency in trials for thalassemia. And similar drug is itapuvivat. It is FT4202, and it is a oral small molecule, again protease kinase receptor activator similar to mitapivat, and mechanism increases ATP and oxygen binding and stabilizes RBC membrane. Next slide. So another drug is hydroxyurea, which is working very well in thalassemia intermedia. But in some cases, we are using hydroxyurea in thalassemia major also. It induces HbF production, and WHO essential medicine, a mechanism, it inhibits DNA synthesis, stressed erythropoiesis, and it increases fetal hemoglobin and reduces ineffective erythropoiesis. Another drug which is there, which I have not come across, but it is there in the literature, rapamycin, sirolimus, lipophilic macrolide is mTOR inhibitor, and mechanism inhibits TORC1 and promotes autophagy and removes excess free globin, and effects improves erythroid maturation and red cell quality. Next slide. Another drug is there, which is decitabine. It is a cytosine analog used in myelodysplastic syndrome. Mechanism, it is inhibits DNA, demethylized DNA, reactivates gamma globin gene, and its effect increase HbF production, improves HB balance, lowers transfusion need, and safety is mild, reversible drop in WBC count. Another drug is thalidomide, which is immunomodulatory drug derived from glutamic acid. Mechanism, it activates P38 MAP, increases histone acetylation and induces gamma globin and erythropoietin. It increases HbF and RBC production, reduces transfusion. Caution, it may cause drowsiness, anxiety, and sleep issues, and in pregnancy, like in ladies, which has to be very cautiously, it has to be used because it has got teratogenic effect. Next slide. So another molecule which has come into the picture is hepcidin. Is a liver-produced hormone, is the master regulator of iron balance. It controls absorption and release by degrading ferroportin. In thalassemia, hepcidin levels are abnormally low due to ineffective erythropoiesis and chronic anemia, and low hepcidin allows iron absorption from the gut. So therapeutic strategy aim to restore hepcidin activity, thereby preventing secondary iron overload. Approaches include mini hepcidin, hepcidin agonist, and TMPRSS6 inhibitors and erythropoietin inhibitors. Increasing hepcidin improves erythropoiesis by reducing iron toxicity in developing red cells. Preclinical and early clinical trials show that hepcidin-based therapy can lower iron absorption, improve red cell health, and may complement iron chelators and agents like luspatercept. Next slide. So these are the summary table which I have used. The luspatercept basically blocks TGF-beta, SMAD2/3 signaling, and promotes RBC maturation and fewer transfusions. Sotatercept, again, it blocks GDF11, increases HB and RBC count. Mitapivat activates pyruvate kinase enzyme, boosts RBC energy and lifespan of the RBCs. And itapivat is again protease kinase receptor activator, and it improves RBC function. And hydroxyurea induces HbF, it increases fetal hemoglobin. So it disbalances, it has been corrected by gamma globin alpha and beta chain exist in they restore it. And it inhibits in rapamycin, TORC C1, removes excess globin chains, and decitabine DNA demethylation reactivates gamma globin gene and activates thalidomide MAP pathway, increases HbF and erythropoietin, and hepcidin regulates iron balance, correct ineffective erythropoiesis. Next slide. So the newer therapies, even the gene therapy comes into the newer therapies, which we have a very elaborate session by two scientists who have talked a lot about this gene therapy. Is a Exaccel hexagonous automasil Casgevy is approved by the FDA in January 2024, utilizes CRISPR-Cas9 technology. Approximately 90% of the patients with transfusion-dependent beta thalassemia achieve transfusion independence following treatment in clinical trials. The main thing is the cost. And Beticel beta globin automasil Ginteglo uses a modified lentiviral vector shown excess in treating severe forms of beta thalassemia. Multi-phase center phase 3 trials reported transfusion independence in 89% of the patients. And cure is the bone marrow transplantation, which has been in everywhere now. They are doing this bone marrow transplantation to cure the thalassemia and sickle cell anemia and other disorders. Next slide. Thank you.
Excellent. Thank you so much to both Dr. Yap and Dr. Suman. We have one question in the Q&A, and whoever might be willing to answer it would be great. So, do sickle cell disease prevents from acquiring HIV?
No. Sickle cell disease doesn't prevent acquiring HIV.
Yeah, thank you. I just had to ask the question as presented.
Great. Can I add on? Hi, Dr. Suman. Dr. Suman Jain.
Hello. Hello.
I just looked it up lah. They have done some studies in US.
Mhm.
I think apparently the sickle cell patient has reduced incidence of HIV. But as far as historically, we all know sickle cell is protecting against malaria infections.
Malaria, right.
Yes,
But
that is real.
we have got patients with sickle having a HIV, but the sickle cases doesn't need transfusions so frequently like thalassemia. Sickle cell disease,
Yeah,
we
but
don't give transfusion. If it is below 7 only, we give transfusion in sickle cell disease. So they get less
No, the-
transfusion compared to thalassemia.
correct. The reason why the malaria parasite cannot survive in the red cells because they get oxygenated and polymerized and died premature.
Thank you. We have to move on to other questions. There's one question that's actually always asked, and I believe we need to discuss it again, is given the gene therapy now, which offers near curative potential for transfusion-dependent thalassemia, what are the ethical, financial, and infrastructural challenges in making such therapies accessible in low and middle-income countries?
That is a very, very complicated
Yes, and I
question.
think it was discussed during the earlier presentations.
Gene therapy is very, very good because it is the same like it is autologous and thing is that we need lot of approval from the government, and also because what she was talking about, we can import where it has been manufactured, then the cost will reduce, and the government, like in India, for the hemophilia, it has been done, gene therapy, and it has been very affordable. Like it is around, in Indian currency, we will say 25 to 30 lakhs when the hemophilia thing has been cured by giving gene therapy. And it has been done in few of the government institute in India, like in Mumbai, in ICMR, supported hospitals, and which is showing a very good result. But in thalassemia and sickle cell anemia, we are working towards that. And if it has been approved in the local government, in local place, then the cost will reduce. But if we have to import from other country, then the cost will be very high. And definitely it is giving a good result. And I
Yeah.
feel the future is gene therapy.
Yeah, thank you.
Future
Thank you
is
so
gene
much. That's very interesting and exciting to know that this is happening in India. Doctor, you have anything to add on that?
No, I think the way forward is to home brew basically to do a
Yeah.
gene therapy. You just have to do it ourselves. Then it will actually be accessible for everyone.
Yes.
Another question, with the emergence of the new pharmacological agents, which Dr. Suman just talked about, luspatercept, metapivat, and others, how can clinicians balance traditional iron chelation therapy with these novel treatments to optimize patient outcomes and reduce transfusion dependency?
Yes, the thing is that these drugs, we have to balance between the blood transfusion and iron chelating drugs. And in my experience, if the patient is maintaining hemoglobin 9.5 pre-transfusion hemoglobin, and with iron chelating drugs, if the serum ferritin level is less than 1000 and T2 star MRI is showing normal iron load in liver and cardiac tissue, then they had a very good life. But the luspatercept is what we are doing. We are in the clinical trial on non-transfusion dependent thalassemia, and we have got 3 patients enrolled with luspatercept. What we found that there is a delay in transfusion, and we have given around 8 doses, and they are not needing transfusions now. But the thing is that it is lifelong treatment, and per month the treatment cost will be 1 lakh. Who will bear the cost of the treatment? Because you are not reducing the transfusion, you
That's
have to
always
give
the
this drug
challenge.
lifelong. So the cost will be the factor which has to be taken into consideration. And mitavivat and the other drugs are in the investigational stage, and the
Yeah,
trials are going on.
good. Dr. Yap, anything to add?
I have one experience with luspatercept that successfully changed the life of my thal major from transfusion dependent to transfusion free. That's only one. The rest, like what Dr. Suman Jain has said, well, not really that successful in a sense, right, Dr. Suman?
Sure.
Thank you, thank you.
Thank you. Before we
But
conclude, I have
I agree with the Yap, Mandy Yap, for prevention is better than cure.
yes, yes. Well, that
Prevention
was
is
my
better than
next question for Dr. Yap. Is Dr. Yap, have we seen a reduction in a new incidence of thalassemia, whether locally or globally?
Locally, no, in my country.
Okay. Yes, I mean Asia. That's the part that has highest incidence of thalassemia.
But
Yes.
I went to UK and they successfully control it.
Yes,
Like
some countries have it, but
Cyprus has done it, and
yes,
there is one study from
Italy.
Taiwan. They are doing antenatal screening for national hemoglobinopathies control program. They have successfully controlled from 15% of hemoglobinopathies. It has come down to 0.001%.
sure.
So, but it has to be recurrent. This thing has to be done. Antenatal screening has
Excellent.
to be done.
Excellent. No, that puts some optimism that it's doable in many countries. That's what I want us to leave with. And one quick question, but I think we're out of time. Is any hope for enucleation agent, Dr. Suman? Anything in the
What?
pipelines? Any new
Which
drug for iron chelation?
in India, a lot of people are now working, and we want to set up with the like multicentric studies with thalidomide.
Okay.
With thalidomide, and the newer generation of thalidomide is also there. I'm forgetting the name, raclumide or something. It
Lenalidomide.
is been shown. Huh? Yes.
Is it lenalidomide you're talking
Yes,
about?
yes,
Yes.
yes. It is working very well, but you have to have a lot of precaution, and it is
Sure.
a low-cost drug than luspatercept,
But it has
and
risks.
hopefully it will work. And if we do the multicentric study with lot of gene analysis and all those things, what we are doing in luspatercept, if those type of studies can be done, then it will give a beautiful result.
Thank you very much to both of you. This has been very informative, very educational, and we appreciate you giving us your time and sharing your knowledge. Thank you so much. Hope we see you again.
Thank you.
Thank you. Yeah, thank you.
Thank you. Bye, everyone. You can join us on the other sessions now.